Hello, good morning. Is my
Oh,
scene
we can
clear?
we can see your screen, Dr. Ijama. You can go ahead, please.
Thank you. Good morning, my teachers and colleagues. My name is Dr. Njonka. This morning we'll be taking the practice question number 3. And the question says, a 53-year-old man with low back pain being evaluated for multiple myeloma. Chest x-ray showed an osteolytic lesion. Urine showed Ben Jones protein. Take a history from the patient. B, what will be your physical examination findings? C, which other 6 investigations will you do? Then what investigations will help in making a prognosis for the patient? Which chemotherapy regimen will you give? And what are the supportive treatments? So the first question says, take a history from the patient. From this patient, I would like to ask about pain, how long it has lasted, the character radiation, aggravating and relieving factors, and if worse at any time of the day. And if there's any other location of pain, whether abdominal pain, or if he has, ask him about swellings on his body, that's thinking about subcutaneous nodules, or if he has changes in his skin color. I will also ask this patient about weakness in his limbs. Also ask him about abnormal sensation in his limbs, thinking about paresthesia. And if there's any focal weakness, any generalized weakness or fatigue. We want to know if this patient has fever, cough or chest pain or shortness of breath. Is there any history of early morning facial puffiness, leg swelling, or reduced urinary output? The second question says, what will be your physical examination findings? On general exam, I expect to see a chronically ill-looking man, probably in respiratory distress, pale and icteric, and with peripheral lymphadenopathy, with a bilateral pitting ankle or leg edema with subcutaneous nodules. The acronym HENT will also help me examine the head, the eye, the nose, and the throat for scalp lesions. Also, I want to look at the tongue, if he has a large tongue, when I'm thinking about amyloid deposition. Then extramedullary plasmacytomas, will expect to see lesions in the orbit, the ear canal, gastric, rectal, and prostatic. While thinking about amyloidosis in this patient, I will want to examine to see if he has a shoulder pad sign, which is a swelling around the shoulders that is usually rubbery. I've talked about macroglossia and then skin lesions. Okay. Then for the bone, if he has bone tenderness or pain without tenderness, which is said to be typical of multiple myeloma, and also to examine for pathological fractures. In neuro exam, I want to know if he has a sensory level, the Tinel sign or Fallen sign that tells me he has a hypercalcemia. For the cardio exam, if he has anything pointing to a cardiomegaly, that's having a displaced apex bit. The abdomen, if he has a distended abdomen, indicating a hepatosplenomegaly. So which other 6 investigations will you do? I would like to investigate to evaluate for clonal plasma cells. So the diagnosis has been given to us, but bone marrow aspirate and biopsy is the gold standard for making this diagnosis. And for histology, we want to know if there are kappa or lambda chains. Then to evaluate the clonal paraprotein, I want to do serum protein electrophoresis and immunofixation to quantify the serum immunoglobulin levels, IgG, IgA, and IgM, a 24-hour urine protein electrophoresis and immunofixation, the serum free light chain and the ratio of the chains, immunofixation for IgD or IgE in select cases. If I want to do investigations to evaluate end organ damage, I'll do a full blood count assess for anemia, renal function test, and to check the serum calcium. A skeletal survey will help to evaluate bone lesions. A PET, CT, or MRI for detecting thoracic and lumbar spine lesions or paraspinal involvement, or if there's an early cord compression. Another question says, what investigations will help in making a prognosis for this patient? In prognosticating these cases, usually investigate for beta-2 microglobulin and serum albumin, which is what is seen in the international staging system. And then the fluorescent in situ hybridization is also done to check for chromosomal abnormalities. Also want to check the LDH. So this will help us to use the values of the beta-2 microglobulin and then checking for chromosomal abnormalities and LDH. We'll stage the patient into stage 1, stage 2, or stage 3. Stage 1 has a median survival of 62 months. Stage 2, median survival of 42 months, and stage 3, a median survival of 29 months. But in this international staging system, the beta-2 microglobulin and albumin is used, but there's a revised staging system where the FISH and LDH is employed to stage the patient into stage 1, stage 2, and stage 3. The next question says, which chemotherapy regimen will you give? That depends on what is being done for the patient. Induction therapy for transplant eligible patients, usually they get lenalidomide, bortezomib, and dexamethasone. The acronym RVD or VRD can be used, or they have placed on daratumumab, bortezomib, thalidomide, and dexamethasone, which is for induction for patients that are eligible for transplant. They're maintained with lenalidomide, ixazomib, and bortezomib. For non-transplant candidates, primary treatment will include lenalidomide and dexamethasone, or daratumumab, lenalidomide, and dexamethasone, or daratumumab, bortezomib, melaphalan, and prednisolone. The next question says, what are the supportive treatments? Other supportive treatments will include a low-dose radiation therapy and also analgesics for pain. Hypercalcemia is also treated with biphosphonates and hydration. Patients can also be transfused with blood products. That's to replace red blood cells and other cell lines. Erythropoietin has also been shown to be helpful in these patients. Other infections can also be treated. It has been suggested the immunoglobulin therapy can also be used. Adequate hydration to prevent kidney failure and to avoid nephrotoxic drugs such as NSAIDs in this patient. I would like to talk briefly on multiple myeloma. It's a plasma cell malignancy in which monoclonal plasma cells proliferate in the bone marrow, resulting in an overabundance of monoclonal paraprotein. Abundance of monoclonal paraprotein, destruction of bone, and displacement of other hematopoietic cell lines. The signs and symptoms will include bone pain, pathologic fractures, spinal cord compression, weakness, malaise, bleeding, anemia, infection, hypercalcemia, kidney failure, neuropathies. The pathophysiology, the development of multiple myeloma is commonly preceded by the multiple MGUS, is a pre-malignant condition that results when plasma cells undergo mutations that restore their capacity for proliferation. The plasma cell proliferation causes extensive skeletal destruction with osteolytic lesions, anemia, and hypercalcemia. Isolated plasmacytomas, which usually affects 2 to 10% of patients, will lead to hypercalcemia, through production of the osteoclast activating factor. They also have destruction of bone and its replacement by tumor that will lead to pain, spinal cord compression, and pathologic fracture. The mechanism of spinal cord compression symptoms may be the development of an epidural mass with compression, a compression fracture of a vertebral body destroyed by multiple myeloma, or rarely an extradural mass. Bone marrow infiltration by plasma cells will result in neutropenia, anemia, and thrombocytopenia. The most common mechanisms of renal injury includes direct tubular injury or through amyloidosis or involvement by plasmacytoma. They could also have renal hypercalcemic nephropathy, hyperuricemia due to renal infiltration of plasma cells, light chain nephropathy, amyloidosis, and glomerulosclerosis. General pathologic processes include the hyperviscosity syndrome. The syndrome is infrequent in multiple myeloma and occurs with overproduction of the immunoglobulins. Sludging is noticed in the capillaries and can result in purpura, retinal hemorrhage, papilledema, ischemia. So etiology could be genetic, environmental. Then you have the MG undifferentiated and the SMM. Sorry, I've forgotten the names of this thing. Chronic inflammation, infection, and radiation. These are the possible etiologies. So the monoclonal gammopathy of undetermined significance, which is the MGUS, is defined by the presence of 3 criteria, as I've stated here: the serum monoclonal M protein less than 3 grams per DL, bone marrow plasma cell concentration less than 10%, and then no evidence of end organ damage. Then the smoldering multiple myeloma is present when the concentration of plasma cell more than 3 grams per DL and the bone marrow plasma cell concentration is more than 10% without end organ damage. So these are the kind of pre-malignant conditions that can lead to multiple myeloma. So these are the subtypes: light chain, non-secretory, solitary, extramedullary, the monoclonal gammopathy of undetermined significance, smoldering, immunoglobulin D, immunoglobulin E. Management generally guided by results of the diagnostic workup and then initial classification of the patient's illness into these subtypes. And treatment plan includes different phases. The induction therapy, consolidation, and maintenance is also done. Other treatment options: chemotherapy using cyclophosphamide, other targeted therapies like proteasome inhibitors and monoclonal antibodies. Immunomodulatory drugs and steroids are used in managing these patients. Bone modifying drugs like zoledronic acid, that's for hypercalcemia, immunotherapy, bone marrow stroke stem cell transplantation, radiation therapy, and surgery can be employed to relieve specific symptoms. Thank you. These are my references.
Well done, Dr. Ijama. Well done. It's actually a very good one. It's a nice presentation. I think we entertained contributions, comments from the group. Well done. It's a good one. I think, okay, maybe before people's comment, it's actually a very good one. I just want to have you, part of the history that you said you look for jaundice, Abby? So I don't know. Is it okay? You said there may be icteric. Is it because of the hemolysis, because of the infection? I don't know.
Yes.
I know they have pallor. You look for pallor because of anemia. It's invariably in them. So why do we look for icteric?
I said, well, on general exam, the patient may be icteric. That's from what could cause that?
I was thinking, is it recurrent infection from, they have recurrent infection, hemolysis or something like that? Just wanted some clarification.
Hepatosplenomegaly, but I'm not really sure how that will cause jaundice for them.
Maybe recurrent infection, can cause hemolysis. And I don't know whether they are associated with autoimmune hemolytic anemia. That will also make them to have hemolysis. Then my second question is, You said you look for features of hypercalcemia. You highlighted abdominal pain. You highlighted nausea, vomiting. And you said you also look for presence of Tinel and Fallen sign. I was thinking there for carpal tunnel syndrome. I don't know.
No, is well, hypercalcemia can lead to that carpal tunnel syndrome. They can have, that's the compression of the median nerve from hypercalcemia.
Okay.
So when you do that exam, you have the Tinel. I used to know Tinel and Fanel sign for hypercalcemia.
Okay. Because the commonest cause of carpal tunnel are amyloidosis, Cushing's,
Yeah,
rheumatoid
exactly.
arthritis, hypothyroidism. Yeah. Thank you. Thank you. It's a good one. Thank you. Okay, so there is a comment from the chat. Dr. Olalekan said, "Good morning. Thank you for the lucid presentation. What team comprises the multidisciplinary approach to the management of multiple myeloma? Who takes the lead in the team? Thank you."
Okay, the oncologist and the hematologist will take the lead. Then other specialties like the nephrologist will also be involved, the cardiologist, the gastroenterologist, and also the microbiologist, because they can also have intercurrent infections. Patients will also be seen by the physiotherapist and well, I guess there could be others, but this is what I can remember now.
Okay, thank you. Dr. Anthony, you want to say something? Go ahead, sir.
Okay, please. Thank you for your presentation. I was in the first place, I was thinking that in this practice question that you were supposed to have something like it's supposed to be a history station and somebody will be answering the questions, more like a simulator. That's what I thought. But nevertheless, I think your history was detailed. But I just have one or two things. First, we must, yes, multiple myeloma is, and it's a abnormality of plasma cells. So when you talked about the variants, I think what I know is that that it goes from monogamopathy of unknown significance to smoldering multiple myeloma, when there are, so to say, mutations which will eventually become multiple. So eventually, it's like a spectrum going from monogamopathy of unknown significance to smoldering multiple myeloma to sometimes to ovate multiple myeloma. And then secondly, too, when you were talking about the myeloma, when you're talking about, because you didn't talk about, when you were talking about diagnosis, you didn't really discuss, you didn't tell us about what are called the myeloma defining events. You just talked about that which you find in smoldering multiple myeloma, talked about that you found which in MG, monogamopathy of unknown significance, but it didn't tell us how to diagnose the diagnostic criteria for multiple myeloma, which besides the crab, about one or two other things based on the levels of the serum free light chain. So you didn't really talk about that. That is another aspect. Now, if we go to the treatment modalities, you talked about, I don't know whether you mentioned, in addition to the chemotherapy, because remember, we have to look at this in stages, whether patient is symptomatic or patient is not symptomatic. Because if at the early stages, both in MGUS and smoldering multiple myeloma, most times there may not be any indication for treatment, but some books will say, well, if patient has maybe has MGUS, it might be better to start them on botuximab and there's the dexamethasone to see whether you can slow down the progression. But in addition to, because there's a lot of things, because you have to look at chemotherapy, you have to look at plasmapheresis. In some cases, in patients, you may need to do dialysis, especially those who have developed myeloma cast nephropathy or those who have developed other complications. And in some cases, they have also talked about what I call autologous stem cell transplantation. So depending on the kind of patient you looked at. So sorry, I was just trying to tell you that, you didn't talk about the myeloma defining events in case of diagnosis, and you didn't add the possibilities of dialysis, especially if patient needs it. I don't know whether you talked about transfusion, because patient might also use, in addition to blood transfusions, patient can also benefit from use of what are erythropoietin stimulating agents, like all those erythropoietin that will give to patients who have anemia, renal failure. Anyway, thank you for your contribution. Thank you for your talk.
Thank you, sir. Thank you.
Thank you very much. We still entertain some comments. Go ahead, sir.
Good morning. Good morning.
Good morning, sir.
Yeah. Thank you for your presentation. I just joined now. I just joined where you where the presenter was talking about carpal tunnel syndrome and then hypercalcemia. So since it's an academic gathering, so we just have to put the facts very straight. So I think that for the purpose of the exam, I think you should maybe not don't put it in your head that hypercalcemia is maybe it might be a cause indirectly, but for carpal tunnel syndrome, it's not one of the things that would come high up. So, and then you said that Tinel sign and Fallen signs, you used to know that they were for hypercalcemia, but no, they are not for hypercalcemia. They are for carpal tunnel syndrome. So they are not, definitely not for for hypercalcemia. Okay, we're talking about Trousseau sign and Trostek sign for hypercalcemia, not Tinel sign and Fallen sign. And if you are talking about causes of carpal tunnel syndrome, the ones that should come easily to you should be things like frequent use of the wrist. Like you could see maybe like a scenario that we talk about, maybe like a gardener, things like that. So that that could lead to carpal tunnel syndrome. But in terms of diseases, the ones that should easily come to you are things like hypothyroidism, hypothyroidism, myxedema. Then you talk about acromegaly, multiple myeloma, like you said, rheumatoid arthritis. The moderator also mentioned amyloidosis, very important. Sarcoidosis, very important. Pregnancy, very important. So those are the ones that usually you need to remember: hypothyroidism, acromegaly, myeloma, rheumatoid arthritis, amyloidosis, sarcoidosis, pregnancy. They are very, very important. And then the Tinel and Fanel sign are for carpal tunnel syndrome. Thank you.
Thank you, sir.
Thank you for the question. Thank you.
You're welcome.
Any more? I think if we don't have more, the second presenter should start getting ready. I don't know whether Dr. Precious Jane or Dr. Ajibola Sanda, one of them should start sharing the screen. Okay, go ahead, please.
Good morning, our facilitators, teachers, consultants, and my colleagues. I'll be taking practice question 2 from the November 2021 NPMCN exam. So the question goes, a 35-year-old woman with 3 pluses of protein in urine, urea of 24 millimoles per liter, and creatinine of 268 micromoles per liter. Not a known diabetic or hypertensive, has pedal edema with normal renal size on ultrasound scan. 1, mention 3 differential diagnoses. 2, what is the most important investigation? 3, no, this is my question. So a histological picture of light microscopy with tubulointerstitial sclerosis, scarring, atrophy, and marked cystic dilatation of the tubules was shown to you. 3, what is your final diagnosis? 4, which 4 investigations will you do? And then 5, what is the latest drug combination for antiretroviral treatment? So my differential diagnosis will include a chronic glomerulonephritis, systemic lupus erythematosus causing lupus nephritis because of the, so CGN, because of the age of the patient, the amount of protein she's losing in the urine, which shows that it's most likely a glomerular disease. She's losing about 3 pluses of protein in the urine, which is equivalent to about 300 milligrams per DL of protein if we're quantifying it. So it's already in the range of macroalbuminuria. So this is focusing on a glomerular pattern of disease, and then also the age. And they also give a history of being not a known hypertensive or diabetic. Lupus nephritis, because of the age of the patient and the sex of the patient, like we know it is commoner in women of childbearing age. HIV-associated kidney disease, which could be either HIVAN or HIVIC, given the fact that she is in a reproductive age, so is most likely sexually active and can have a sexually transmitted infection, of note being HIV, which can also cause a glomerular lesion. So the second question says, what is the most important investigation? So a patient who is spilling this amount of protein in the urine with deranged urea and creatinine, the most important investigation will be a kidney biopsy. Then the next thing says that we're shown a histological picture of light microscopy with tubulointerstitial sclerosis, atrophy, and marked cystic dilatation. And those findings are in keeping with HIVAN. In HIVAN, what you usually see is marked cystic dilatation, although you also have the classic. So HIVAN is the classic collapsing FSGS. So what you usually see in patients with HIVAN is cystic dilatation in the tubules and also collapse of the glomerular duct. So given the histological picture that was painted, the patient can it can be seen as HIV-associated nephropathy. The next question is, what other 4 investigations would you like to do? So I would like to do a CD4 count, and what you usually see in them is a CD4 count of less than 200. I would like to do a viral load, a full blood count to check for things like anemia, if she has an ongoing infection that might have precipitated an AKI on maybe a background CKD, and also our urine protein creatinine ratio. This is to quantify the amount of protein that the patient is actually spilling in the urine. And the next question goes, what is the latest drug combination for antiretroviral treatment? So the latest drug combination is usually the dolutegravir-based regimen, which will contain dolutegravir, tenofovir, dolutegravir being an integrase strand inhibitor, tenofovir, which is a nucleotide reverse transcriptase inhibitor, and then also lamivudine, which is a nucleoside reverse transcriptase inhibitor. But in a patient with HIV-associated nephropathy who already has features of renal impairment, we prefer to use tenofovir alafenamide to avoid the renal nephrotoxicity associated with tenofovir disoproxil fumarate. So I just gave a very short note on HIV-associated nephropathy. So kidney disease is the 4th leading cause of death amongst patients with retroviral disease. Up to 30% of HIV patients in the US have CKD or proteinuria, and HIV is the leading cause of end-stage renal disease among African American men. With HIV is the leading cause of end-stage renal disease among African American men. Burden of kidney disease, that's in the US. Burden of kidney disease among HIV patients is not clear worldwide, especially in sub-Saharan Africa, but estimates of CKD prevalence among them range from about 5 to 50%. So in patients with HIV, there are a number of renal affectations that they could have. They could have the classic HIVAN, which is what we described earlier, which is the collapsing variant of FSGS. They could have HIVIC, which is HIV immune complex disease, which is a constellation or contains different glomerular diseases, which can be IgA nephropathy, it can be membranous nephropathy, it can also be the membranoproliferative glomerulonephritis. They could also have the thrombomicroangiopathies. They could have, because HIV and hepatitis B and C, usually you find them co-infected in other patients. They could also have hepatitis B related kidney disorders, which can cause membranous nephropathy. They can also have hepatitis C causing MPGN like with cryoglobulinemia. They can also develop diabetes from treatments and have DM nephropathy, and also other infectious glomerulonephritis from opportunistic infections affecting the patient and causing a renal impairment. So, but HIVAN is a unique glomerular disease that is a result of effect of active HIV replication within the kidney tissue itself, and is characterized by 4 pathological changes in the kidney. You have hypertrophy and hyperplasia of the podocytes to the point that it caves in the capillary duct, in the capillary tuft, and reduces the filtration area of the glomerulus. You have marked microcystic dilatation of the tubules, interstitial nephritis, which is usually infiltrated with CD8 cells, and tubular-reticular inclusion bodies. So the pathophysiology of HIVAN, what has usually been seen is that in patients with HIVAN, the HIV virus itself is the one that is affecting the renal tissue. And some studies have postulated that, in fact, what you actually have is viral replication ongoing in these tissues. But of note is that you usually see HIV-associated nephropathy in patients of African ancestry, and even in the Americas, you see it among African Americans. And this has been postulated that it is due to the presence of the ApoL1 gene, which is found in areas where you have endemic trypanosoma, which is the sleeping sickness, as the ApoL1 gene is protective against the trypanosoma disease, both the rhodiense and the gabiense, depending on either it's the G1 or G2 genetic variant that the person has. So in patients who have the ApoL1 gene and have retroviral disease, it's sort of like a second hit that propagates the ongoing injury and leads to podocyte effacement, scarring of the tissues, cystic dilatation, which will now cause the salt-losing enteropathy, which is why the classic HIV patients are usually, the classic HIVAN patients are usually dry and not hypertensive. So you also have direct viral effects from the virus itself. So in patients who have the HIV-1 DNA, the mRNA causes direct injury to the glomerulus of the kidneys and active replication within the renal tissue, and can cause production of cytokines within the renal interstitium and cause scarring, sclerosis, and atrophy. Also, there are some genes that have been found to be very important for different aspects of the kidneys. So the NEF gene, this is usually seen in patients who have characteristic glomerular lesion, and the VPR gene for those who have tubular pathology. These are very important for nephrology subspecialty MCQs. So like I said, the mechanism of kidney injury could also have opportunistic infections, which can cause an immune-like pathology, which will lead to cytokine release, further propagation of cytokines, dysregulation of the immune system, and worsen the renal injury going on, infection of the renal cells, toxicity due to HIV accessory proteins. And we've also mentioned the importance of the African descent. Also of note that one of the disorders I didn't mention is the drugs themselves. So the drugs themselves can also cause toxicity in patients with HIV. So the clinical presentation usually affects patients of African American ancestry. They can present with low CD4 count that we mentioned. Edema and hypertension are typically absent because of the salt-losing enteropathy that you have in these patients. They could have massive proteinuria because they have effacement of the podocytes and destruction. They could have microhematuria, azotemia, rapid progression to end-stage renal disease. They're usually normotensive. And we mentioned earlier that their kidneys are usually large and echogenic, which is due to the marked cystic dilatation that you see in them, so that by the time the renal impairment progresses, instead of, so in some of them, instead of seeing the large echogenic kidneys, you see a normal sized kidney, which could be one of the reasons why our patient here had a normal ultrasound scan. So for treatments for HIV-associated nephropathy, one of the commonest things, worthy of note to mention here is that HIVAN has been on the decline since the initiation of highly active antiretroviral therapy or combined antiretroviral therapy. And what you usually see in studies that have been released over the last couple of years, especially from South Africa, is we see HIVIC. So there's more of HIVIC than HIVAN because of the introduction of our highly active antiretroviral therapy. So for treatment of HIV-associated kidney disease or HIVAN, we want to start the patient on antiretroviral therapy, as HIVAN has been shown to be a reversible disease. You can have actually, if the patients are caught early enough, they can be reversal of the injuries that have started ongoing in the person's kidney. You also want to initiate your ACE inhibitors. This has been helpful with proteinuria. You also want to give your ACE inhibitors, as this has been found to be protective in terms of reducing the proteinuric effect from the injury. In some studies, short courses of steroids have been found, and this has been found to be helpful in patients who have dysregulated immune response, especially in those who have inflammation. And this is more in patients with HIVAN than in HIVIC. Steroids have not been found to be useful in patients with HIVIC. So, and then if the patients have progressed to end-stage renal disease and now has pictures of uremic symptoms, you want to commence them on renal replacement therapy, which could be hemodialysis, peritoneal dialysis, and kidney transplants. HIV patients now do well on kidney transplants. There is a study called the HOPE study, which was done and has found that they found the beneficial effect and the survival, the 1 year and 5 year survival of HIV patients who have had a kidney transplant, and the 1 year survival was comparable to their non-HIV or patient of diabetic kidney disease. And there was a slight decrease in the 5 year survival. Thank you very much.
Thank you very much, Dr. Ajibola Sanda. It's a very good one. The message is well delivered. Thank you once again. We entertain comments, addition, clarifications. Any comment, please? Okay, maybe before, I'll just have some comments and maybe a question. Thank you very much. It's actually a very good one. I just want to emphasize that from the history, one of the things we should also consider is lupus nephritis, as we highlighted. Lupus is very good differentials here, looking at the history, looking at the age of the patient, looking at she doesn't have hypertension and diabetes, and she has pedal edema and the size of the kidney on ultrasound. So lupus is also very good. But I believe HIVAN maybe she will take more weight. Then one of the things, again, in some region where the sickle cell is common, we should also consider sickle cell disease can present with this, and more so that with the normal size kidney, they can have normal or reduced size of the kidney, and they could present like this in the absence of hypertension and diabetes. Again, I just want to ask again, in the treatment, must we stick to tenofovir base? Because you give us option of using alafenamide. Must it be that we have to depend on the creatinine level, or we should shun away from tenofovir at all? Because if it's hepatitis B, we are dealing with co-infected with HIV, we will have some benefit of using tenofovir. But in this case, we just want to treat the HIV. We have other options that do not, to some extent, have effect on the renal function. I just want to us first try tenofovir despite not being renotoxic, or we should completely avoid, or we use creatinine as a guideline. This is just my question. Thank you. It's very good one. Thank you. Okay. Please, can you respond before somebody wants to?
Yes, please. So The treatment for HIV in patients will depend on the region and what the guideline says as to what are the drugs for treatment in that particular region. But I was just emphasizing on patients who have HIV-associated kidney disease. I was just emphasizing on patients who have HIV-associated kidney disease and talking about the toxicity of the tenofovir in patients with retroviral disease, and giving us options that instead of using tenofovir disoproxil fumarate, we can use tenofovir alafenamide if we want to use the tenofovir based regimen for patients with retroviral disease. As tenofovir forms one of the baseline medications for patients with retroviral disease. So other options can definitely be used.
Okay. Thank you, boss. Okay. Thank you very much. Dr. Dalhatu want to say something. Go ahead, please.
Okay. Thank you, sir, for the wonderful presentation. It's a nice presentation. We learned a lot from the presentation. My comment is concerning the drug choice. Actually, for patients with HIVAN, it's safer to avoid tenofovir regimen completely in them, especially with end-stage disease or very low creatinine clearance. Remember, both TDF and TAF, they are tenofovir-based regimen, which is a prodrug. And the reason why sometimes we prepare TAF against TDF is because of the component of they are both prodrugs actually. For TDF, the concentration is actually extracellular before conversion to the actual active ingredient of tenofovir. But for the TAF, usually the concentration and absorption is intracellular. And that's why the prodrug tenofovir is less nephrotoxic in TAF compared to TDF. So in cases of HIVAN, it's safer to avoid tenofovir-containing regimen completely. It's better to shift to abacavir, which doesn't have nephrotoxicity at all among the nucleoside reverse transcriptase inhibitors. However, the abacavir lamivudine regimen is actually a fixed drug therapy. And the lamivudine also, it has some nephrotoxicity. So the best is to have a loose loose abacavir, loose lamivudine, and then the dolutegravir. But in Nigeria, we don't have it. And what the guideline says, in cases of HIVAN, the Nigerian guideline for HIV treatment, if there is case of HIVAN, you shift to abacavir, lamivudine, and then the dolutegravir-based regimen. Thank you, that's for that. And then just in addition, for why the patient doesn't have edema, apart from salt-losing enteropathy, because in HIV patient, they have a lot of infection, multiple infection, and multiple antibodies. So they tend to have the intravascular, that's oncotic pressure is very good in them. And that's why some of in most cases, they don't have edema, peripheral edema as component of presentation in HIVAN. Thank you very much.
Thank you very much, Dr. Alhat, for the addition. Before we move to the what is in chat box, we have a nephrologist, a colleague, Dr. Lawrence Ade, want to add some more light. Go ahead, Dr. Ade.
All right. Thank you, the moderator. Thank you, Dr. Ajibola, for the presentation. It was a very nice one. I really appreciate all your efforts. But I have a few comments. One concerning the differentials. You made the differential of CGN. Based on the scenario they gave us, they didn't give us the duration of the symptoms. It would have been so subjective to just make a CGN as our differential here. It could be glomerulonephritis, GN, or anyway, it could be either acute or chronic, depending on the duration of the symptoms. Since we're not given the duration of the symptoms, you can just be silent to be a GN, which can be either acute or chronic, depending on the duration of the symptoms. Secondly, this patient obviously has a nephrotic range proteinuria. So nothing stops this, and it's a young person, nothing stops this person from having primary nephrotic syndrome with that's complicated by renal impairment also. It could be primary nephrotic syndrome, other FSGS, MCD, anyone, based on depending on the type that is having renal impairment now as a complication of this primary nephrotic syndrome. Secondly, under the diagnosis, under investigation, how you investigate? You did the CD4, but before you even go ahead and do CD4, it's like better to even do a retroviral screening for this patient to actually confirm that this patient actually have HIV or not. So far, the is showing all the features of IBAN. I think after you have done that, you can now go ahead and do the CD4 and viral load. Those are my contribution. Thank you for the discussion.
Thank you, Dr. Ade, for the addition. We appreciate that. Our chief, Dr. Fatima, wants to add more. Go ahead, ma.
Yeah, thank you very much. Well done, Dr. Sanda, for the excellent presentation. I'm really happy with the comment from Dr. Yahya and Dr. Ade. Those have been in my mind. Looking at the scenario and the differentials we give, we had this same question repeated in our exams. Unfortunately for me, I attempted it during our discussion. So when they ask for these differentials, it's important wherever you are asked differentials, start with the ones that you think are the most important differential. Don't start going to town, because even if you mention like 10 differentials, they will ask you which ones are the most important. And we ask you 3 differentials. They want that 3 differentials. You cannot mention 3 differentials that are unlikely. No, the most likely differentials should be on the top list. 1, lupus nephritis. Yeah, I thought of that. When I mentioned, they said, no, if you can rearrange your differential, starting with the most likely. I just went straight to HIV-associated nephropathy, knowing that this is a question that I have attempted before. So I know the question. I just went straight to HIV-associated nephropathy, secondly, lupus nephritis, and nephrotic syndrome, looking at the young age of the patient and the nephrotic range proteinuria. And going to the investigations. Of course, other investigation, you can't jump to CD4 count without even doing retroviral screen. You must confirm that this patient has the HIV before doing CD4 count, but they are all in line. Yeah, so this is my comment. Wherever you ask differential, please start with the most likely. And whether, no matter how many you mention, they will say, no, limit yourself to the number we ask you. So make sure you mention the most likely differential, because the follow-up questions will definitely answer the most likely diagnosis. Thank you.
Thank you very much, ma. We appreciate your contribution. Thank you. I think let me just quickly read out some chat from the box. Dr. Mamodu said, thank you for your presentation. Is there a role of glucocorticoids in management of HIVAN? Dr. Mamodu also went ahead to answer the question, I think. He said, there is generally no role for routine glucocorticoids in patients with HIVAN, although small observational studies have suggested that glucocorticoid therapy may improve kidney function and reduce proteinuria in patients with HIVAN. These studies were conducted before or early after induction of effective ART, and adverse events were common. In patients whose kidney function is not improving with therapy, the use of glucocorticoids may be considered on a case-by-case basis, weighing the risk of infection and metabolic derangement against the risk of kidney disease progression. He also went ahead to say HIVAN is diagnosed by histology. Prognosis is poor. We monitor patients with HIVAN with serum creatinine level, eGFR, and urine protein excretion by spot urine protein to creatinine ratio or spot urine albumin creatinine ratio with frequency of assessments guided by severity of clinical presentation. In addition, we routinely monitor patients' HIV viral RNA level and CD4 count. Thank you, Dr. Mahmoud. These are the comments from the chat box. They're all from Dr. Mahmoud. I think we go ahead. If there is nothing, we hand over to our teachers, Dr. Christabel. Okay, briefly before that, Dr. Muhammad Usani Abubakar, who is also an ID physician, want to contribute. Go ahead, Dr. Muhammad.
Good morning, colleagues, senior colleagues, teachers, and colleagues. Thank you very much, Dr. Haya, and the organizers of this meeting. All the presentation was nice, lucid, and I think the comments were all in line. And in just addition to what everyone have said, is the issue of use of ART. I think it's worth noting that if you're discussing this kind of case, even though you wouldn't even know the diagnosis first, whether his patients are retroviral positive or retroviral negative, I think in the first place, we have to keep it in our mind that using tenofovir may be a bit counterproductive in this kind of cases. And that's why, as we are discussing the case, you have to be worried of whether the patient has been on antiretroviral therapy or not, because this kind of cases, they are discussion-based, exam-based questions. So you have to establish what, okay, you have to discuss it in two fronts, whether the patient is on treatment, he needs to change, or he's not on treatment, he doesn't need to change. And we should know that currently, I think it was discussed during one of our rounds, there is no any current RCT, randomized control trial, on the benefit of ART on HIVAN. Most of the results seen were more of observational. Okay, patient RVS on treatment, retroviral disease on treatment. Usually there may be delayed progression to end-stage renal disease compared to those that were not. So there are more of observational stories. Same thing with use of steroid in HIVAN. So, but I think it's an area that needs to be studied, maybe especially in our areas where the gender and also the race plays role in development of in development of HIVAN, but it's advocated that tenofovir should be avoided entirely in patient, not even with end-stage renal disease, even patient with moderately impaired GFR. I think we should be discouraged, because the monitoring the patient in our case may be counterproductive, so maybe limited. We may not be able to follow patient regularly the same way like other standard centers. And if you look at it, even the treatment worldwide is changing while we are still sticking with usually the guidelines provided for the Africans. So thank you very much.
Thank you, Dr. Muhammad, for the addition. Thank you. We appreciate that. I think it's time to hand over to our teachers. Chief Dr. Christabel.
Thank you, Dr. Yaya. Thank you so much. The presenters today, the first presenter, and Dr. Sanda, thank you so much. Quite lucid, it was clear, it was detailed. Thank you, thank you. Once again, I must appreciate the active participation from the national guys. I love it, keep it up. Always encourage you that don't forget any aspect of the